Welcome to this video entitled, Clinical Pharmacology of Renal and Electrolyte Disorders. This session focuses on the essential principles of renal physiology and their application in the management of kidney disease. Let's begin with how the kidneys normally work. Every day, large volumes of blood pass through the kidneys. The first step is filtration. Blood enters the glomerulus, where water and small solutes are filtered into the nephron. Larger proteins and blood cells are normally retained in the circulation. Next comes reabsorption. This is the process by which the nephron returns needed substances back into the bloodstream. Water, glucose, amino acids, and electrolytes are selectively reabsorbed. This helps maintain fluid and electrolyte balance. The kidneys also perform secretion. Certain substances are actively transported from the blood into the tubular fluid. These include hydrogen ions, potassium, and many drugs. Secretion helps eliminate waste products and regulate body chemistry. Another critical function is acid-base homeostasis. The kidneys maintain normal blood pH by reabsorbing bicarbonate and excreting excess hydrogen ions. This process works alongside the lungs to keep the body's internal environment stable. Understanding these mechanisms helps us recognize renal disease. Glomerular disorders primarily affect the filtration barrier. Damage to the glomerulus may cause proteinuria, hematuria, edema, and declining kidney function. Different glomerular diseases have distinct causes and treatment approaches. Pharmacotherapy may include immunosuppressive agents, corticosteroids, renin-angiotensin system blockers, and supportive therapies aimed at preserving kidney function. As kidney disease progresses, some patients develop end-stage renal disease, or ESRD. At this stage, the kidneys can no longer adequately maintain fluid, electrolyte, and metabolic balance. Renal replacement therapy becomes necessary to sustain life. Renal replacement therapy includes hemodialysis, peritoneal dialysis, and kidney transplantation. These therapies replace some kidney functions, remove toxins, correct electrolyte disturbances, and manage fluid overload. Drug therapy in end-stage renal disease requires special consideration. Reduced renal clearance can lead to drug accumulation and toxicity. Dosing strategies must account for altered pharmacokinetics. Factors such as drug distribution, metabolism, renal elimination, and dialysability influence dosing decisions. Some medications require dose reduction, while others require supplemental doses after dialysis sessions. End-stage renal disease is also associated with several important complications. Anemia develops because diseased kidneys produce insufficient erythropoietin. Treatment may involve erythropoiesis-stimulating agents and iron supplementation. Chronic kidney disease mineral and bone disorder, or CKD-MBD, results from abnormalities in calcium, phosphate, vitamin D, and parathyroid hormone regulation. Management includes dietary measures, phosphate binders, vitamin D analogs, and calcimimetic agents. Hyperkalemia is another potentially life-threatening complication. Elevated potassium levels can cause dangerous cardiac arrhythmias. Prompt recognition and treatment are essential. Sodium disorders are also common in advanced kidney disease. Both hyponatremia and hyponatremia can affect neurological function and require careful evaluation and correction. By understanding renal physiology, disease mechanisms, and therapeutic principles, healthcare professionals can optimize treatment and improve outcomes for patients with kidney disease. Here is an enriched script suitable for short 6 to 8 second educational video clips. The kidneys are remarkable organs. Their main job is to filter the blood. They maintain fluid balance. They regulate electrolytes, they remove waste products, and they help keep the body's internal environment stable. The functional unit of the kidney is called the nephron. Each kidney contains about 1 million nephrons. These tiny structures work continuously. Together, they process large volumes of blood every day. Every nephron performs 3 major tasks. These are filtration, reabsorption, and secretion. Let's start with filtration. Filtration occurs in a specialized structure called the glomerulus. Blood enters through the afferent arteriole. The afferent arteriole delivers blood into a network of tiny capillaries. This capillary network is called the glomerular tuft. The glomerulus acts like a highly selective sieve. Water and small dissolved substances pass through easily. These filtered substances enter Bowman's capsule. The fluid collected here is called the filtrate. Not everything can pass through the filtration barrier. Large proteins are normally retained in the bloodstream. Blood cells are also excluded. This selective filtering process protects essential blood components. After filtration comes reabsorption. This is one of the kidney's most important functions. The body cannot afford to lose valuable nutrients. As the filtrate travels through the tubules, useful substances are reclaimed. Glucose is reabsorbed back into the bloodstream. Amino acids are also recovered. Large amounts of water are reabsorbed as well. Important electrolytes such as sodium are carefully regulated. This process prevents dehydration. It also helps maintain normal blood chemistry. Without reabsorption, essential nutrients would be lost in the urine. The final major process is secretion. Secretion moves substances in the opposite direction. Instead of leaving the tubules, materials move from the blood into the tubular fluid. This is an active process. It requires specialized transport mechanisms. The kidneys secrete metabolic waste products. They also eliminate excess ions. Hydrogen ions can be secreted to help regulate blood pH. Certain drugs and toxins are also secreted into the urine. This process enhances waste removal. It helps the body maintain chemical balance. Together, filtration, reabsorption, and secretion form the foundation of kidney function. These processes work every minute of every day. They keep the blood clean. They conserve essential substances. And they help maintain homeostasis throughout the body. Understanding these basic renal processes is essential. They provide the foundation for understanding kidney disease. They also explain how many renal medications work. Mastering renal physiology makes clinical pharmacology much easier to understand. The kidneys do much more than remove waste. They are also master regulators of fluid and electrolyte balance. Every day, the kidneys carefully adjust the composition of body fluids. This helps maintain a stable internal environment. One of the most important functions is water balance. The body must keep the right amount of water at all times. Too little water causes dehydration. Too much water can be equally dangerous. A key hormone involved in water regulation is antidiuretic hormone, or ADH. Antidiuretic hormone is also called vasopressin. It is released from the posterior pituitary gland. When the body senses dehydration, antidiuretic hormone levels increase. Antidiuretic hormone acts mainly on the collecting ducts of the kidney. It makes these ducts more permeable to water. As a result, more water is reabsorbed back into the bloodstream. Less water is lost in the urine. The urine becomes more concentrated. When the body has excess water, antidiuretic hormone secretion decreases. More water is then excreted in the urine. Sodium balance is another critical responsibility of the kidneys. Sodium is the major extracellular electrolyte. It plays a vital role in blood pressure and fluid volume regulation. The renin-angiotensin-aldosterone system, or RAAS, is central to sodium control. When blood pressure falls or kidney perfusion decreases, renin is released. This activates a hormonal cascade. Angiotensin II is produced. Angiotensin II constricts blood vessels and stimulates aldosterone release. Aldosterone acts on the distal nephron. It promotes sodium reabsorption into the bloodstream. Water follows sodium. This helps restore blood volume and blood pressure. The body also has mechanisms to prevent excessive sodium retention. Atrial natriuretic peptide, or ANP, and brain natriuretic peptide, or BNP, help achieve this. These hormones are released when the heart senses volume overload. They promote sodium and water excretion. This helps reduce blood volume and lower blood pressure. Potassium balance is equally important. Potassium is essential for nerve conduction and muscle contraction. Even small changes in potassium levels can be dangerous. The kidneys are the primary organs responsible for potassium regulation. Aldosterone plays a major role here as well. It stimulates potassium secretion into the distal tubules. This allows excess potassium to be removed through the urine. Calcium and phosphate balance are also tightly regulated. These minerals are essential for healthy bones and normal cellular function. Parathyroid hormone, or PTH, is a major regulator. When blood calcium levels fall, parathyroid hormone secretion increases. Parathyroid hormone promotes calcium reabsorption by the kidneys. It also increases phosphate excretion. The kidneys contribute further by activating vitamin D. The active form is called calcitriol. Calcitriol increases calcium absorption from the intestine. Together, parathyroid hormone and calcitriol help maintain healthy calcium and phosphate levels. Through these finely tuned mechanisms, the kidneys preserve fluid balance, regulate electrolytes, and support overall physiological stability. One of the kidney's most important jobs is maintaining acid-base balance. Every cell in the body depends on a stable pH. Even small changes in blood acidity can affect enzyme activity. They can disrupt cellular function. They can even become life-threatening. The body works hard to keep blood pH within a very narrow range. The normal blood pH is maintained between 7.35 and 7.45. A pH below this range is called acidosis. A pH above this range is called alkalosis. The lungs and kidneys work together to maintain this delicate balance. The lungs regulate carbon dioxide levels. The kidneys regulate acids and bases over the long term. One of the kidney's key tools is bicarbonate. Bicarbonate is the body's primary chemical buffer. It helps neutralize excess acids in the bloodstream. Every day, large amounts of bicarbonate are filtered through the glomeruli. Losing this bicarbonate would quickly lead to acidosis. Fortunately, the kidneys are highly efficient at conserving it. Nearly all filtered bicarbonate is reabsorbed back into the blood. Most of this reabsorption occurs in the proximal tubule. This process helps preserve the body's buffering capacity. It also maintains a stable blood pH. But bicarbonate conservation is only part of the story. The body continuously produces acids through normal metabolism. These acids must be removed. The kidneys accomplish this through acid excretion. Hydrogen ions are actively secreted into the tubular fluid. However, free hydrogen ions cannot accumulate indefinitely in the urine. Urinary buffers are needed. One important urinary buffer is phosphate. Phosphate binds secreted hydrogen ions. This allows acids to be safely excreted from the body. This process is known as titratable acid excretion. It is an essential mechanism for maintaining acid-base balance. The kidneys also have another powerful strategy. This process is called ammoniagenesis. It becomes especially important during chronic acid loads. In the proximal tubule, amino acids such as glutamine are metabolized. This generates ammonium, also known as NH4+. The ammonium is secreted into the tubular fluid. It is eventually eliminated in the urine. At the same time, new bicarbonate is produced. This newly generated bicarbonate enters the bloodstream. As a result, the body gains additional buffering capacity. This mechanism not only removes acid, it also replaces bicarbonate that has been consumed. Ammoniagenesis is therefore a highly effective defense against acidosis. Together, bicarbonate reabsorption, acid excretion, and ammoniagenesis form the foundation of renal acid-base regulation. These processes operate continuously. They protect the body from dangerous pH fluctuations. When kidney function declines, acid-base disturbances often develop. This is one reason why chronic kidney disease can have widespread effects throughout the body. Understanding these mechanisms provides an essential foundation for clinical nephrology and pharmacotherapy. It also highlights the remarkable ability of the kidneys to maintain physiological stability every day. To understand glomerular disorders, we first need to understand the glomerulus. The glomerulus is the kidney's filtration unit. It acts as a highly selective barrier. Its job is to allow water and small molecules to pass. At the same time, it prevents proteins and blood cells from entering the urine. This filtration barrier has several important components. These include the glomerular basement membrane and specialized cells called podocytes. Podocytes wrap around the glomerular capillaries. They form filtration slits that help control what passes through the barrier. When this filtration system is damaged, glomerular disease develops. The two major clinical patterns are nephrotic syndrome and nephritic syndrome. Let's start with nephrotic syndrome. A useful way to think about nephrotic syndrome is the leaky sieve. The filtration barrier becomes abnormally permeable. Large amounts of protein escape into the urine. This excessive protein loss is called proteinuria. In nephrotic syndrome, proteinuria exceeds 3.5 grams per day. Albumin is the protein most commonly lost. As albumin levels fall, hypoalbuminemia develops. Albumin normally helps keep fluid inside blood vessels. When albumin decreases, fluid leaks into surrounding tissues. This produces the characteristic severe edema. Patients may notice swelling of the legs. Facial puffiness is also common. In severe cases, fluid may accumulate throughout the body. The liver attempts to compensate for protein loss. It increases protein synthesis. Unfortunately, this also increases lipid production. As a result, hyperlipidemia develops. Elevated cholesterol and triglyceride levels are common findings. Nephrotic syndrome also increases the risk of blood clot formation. Important anticoagulant proteins may be lost in the urine. This creates a hypercoagulable state. Patients may become vulnerable to venous thrombosis and other thromboembolic complications. Now let's examine nephritic syndrome. Unlike nephrotic syndrome, nephritic syndrome is primarily an inflammatory disorder. The glomerulus becomes inflamed. This inflammation is often triggered by immune-mediated injury. Immune complexes or autoimmune mechanisms damage the filtration barrier. Inflammation causes swelling and cellular proliferation within the glomerulus. The filtration surface becomes disrupted. Red blood cells can leak through the damaged barrier. This produces hematuria. Under microscopic examination, red blood cell casts may be seen. These casts are an important clue to glomerular inflammation. Proteinuria may also occur. However, it is usually less severe than in nephrotic syndrome. Inflammation reduces the efficiency of filtration. As a result, the glomerular filtration rate, or GFR, declines. Waste products begin to accumulate in the blood. Fluid and sodium retention may also occur. This contributes to the development of hypertension. Patients may present with dark or tea-colored urine. They may also develop edema and elevated blood pressure. Although nephrotic and nephritic syndromes have distinct features, both result from damage to the glomerular filtration barrier. Recognizing these patterns is essential. They provide important clues to diagnosis, treatment, and long-term kidney outcomes. Corticosteroids are among the most important anti-inflammatory drugs used in nephrology. They play a major role in the treatment of many glomerular diseases. These medications help control immune-mediated kidney injury. Two commonly used corticosteroids are prednisone and methylprednisolone. Although they are closely related, they are used in slightly different ways. Prednisone is often given orally for long-term treatment. Methylprednisolone is frequently used intravenously when rapid immunosuppression is needed. To understand how these drugs work, we need to look inside the cell. Unlike many medications, corticosteroids do not act on cell surface receptors. Instead, they easily cross the cell membrane. Because they are lipid-soluble, they enter cells by simple diffusion. Inside the cell, they bind to intracellular glucocorticoid receptors. These receptors are located within the cytoplasm. Once the drug binds to the receptor, a drug-receptor complex is formed. This complex then travels into the nucleus. The nucleus contains the cell's genetic material. Here, corticosteroids exert their most important effects. They regulate gene transcription. In simple terms, they influence which genes are turned on and which genes are turned off. This process changes the production of many inflammatory proteins. As a result, inflammation is significantly reduced. One major effect is the suppression of pro-inflammatory cytokines. Cytokines are chemical messengers that coordinate immune responses. Important cytokines affected include interleukin-1, interleukin-6, and tumor necrosis factor alpha. These molecules normally promote inflammation and tissue injury. By reducing their production, corticosteroids help calm excessive immune activity. This is especially important in immune-mediated kidney diseases. Corticosteroids also reduce the movement of inflammatory cells into tissues. Fewer immune cells reach sites of injury. This further decreases inflammation. Another important effect is the reduction of capillary permeability. Inflamed blood vessels often become leaky. Fluid and proteins can escape into surrounding tissues. Corticosteroids help stabilize these blood vessels. This reduces tissue swelling and edema. Now let's look at the pharmacokinetics of prednisone. Prednisone itself is not fully active. It is considered a prodrug. After absorption, it travels to the liver. In the liver, enzymes convert prednisone into its active form, prednisolone. This conversion is essential for therapeutic activity. The process involves hepatic metabolism, including pathways associated with CYP3A4 enzymes. Once converted, prednisolone circulates throughout the body. It reaches target tissues and exerts its anti-inflammatory effects. Because liver function is important for activation, severe hepatic impairment may alter drug response. Understanding this conversion helps explain differences in patient outcomes. Overall, corticosteroids are powerful immunosuppressive agents. They reduce inflammation at the genetic level. They suppress harmful immune responses. And they remain a cornerstone of therapy for many glomerular disorders. Corticosteroids remain a cornerstone of treatment for many glomerular diseases. Their powerful anti-inflammatory and immunosuppressive effects make them highly effective. In many patients, they are considered first-line therapy. One important condition treated with corticosteroids is minimal change disease. This is the most common cause of nephrotic syndrome in children. Many patients experience dramatic improvement after steroid treatment. Proteinuria often decreases significantly. Kidney function is usually preserved. Another important indication is focal segmental glomerulosclerosis, or FSGS. Focal segmental glomerulosclerosis causes progressive damage to the glomeruli. Many patients receive prolonged corticosteroid therapy. The goal is to reduce inflammation and limit further kidney injury. Although corticosteroids can be highly effective, they are not without risks. Many adverse effects are related to long-term use. One common complication is hyperglycemia. Corticosteroids increase glucose production by the liver. They also reduce insulin sensitivity. As a result, blood sugar levels may rise. Patients with diabetes often require closer monitoring. Hypertension is another frequent concern. Steroids promote sodium and water retention. This can increase blood volume and elevate blood pressure. Regular blood pressure monitoring is therefore essential. Long-term corticosteroid use can also affect bone health. Bone resorption increases while bone formation decreases. Over time, this can lead to osteopenia or osteoporosis. The risk of fractures becomes significantly higher. This is why preventive measures are so important. Eye complications may also occur. One well-known example is cataract formation. Patients receiving prolonged therapy should undergo regular eye examinations. The immune system is also affected. While immunosuppression helps control kidney disease, it can increase infection risk. Even minor infections may become more serious. Patients should be educated about early signs of infection. Mood and behavioral changes are also possible. Some patients experience irritability or anxiety. Others may develop insomnia or mood swings. These effects can sometimes be distressing. Open communication with healthcare providers is important. Several clinical pearls help ensure safe corticosteroid use. One of the most important is proper tapering. Corticosteroids should never be stopped abruptly after prolonged therapy. The adrenal glands reduce their natural cortisol production during treatment. Sudden withdrawal can trigger adrenal insufficiency. In severe cases, an adrenal crisis may occur. A useful rule is, start high, go slow. Initial doses may be high to control disease activity. Dose reductions should occur gradually. This allows the adrenal glands time to recover. Another key counseling point involves bone protection. Calcium supplementation is often recommended. Vitamin D supplementation is also important. Together, these measures help maintain bone strength. Ongoing monitoring is essential throughout therapy. Blood glucose should be checked regularly. Blood pressure should be monitored closely. Bone density assessments may be needed during long-term treatment. With careful monitoring and patient education, corticosteroids can be used safely and effectively. They remain one of the most valuable tools in the management of nephrotic syndromes and other immune-mediated kidney diseases. When corticosteroids alone are not enough, additional immunosuppressive drugs may be needed. These medications help control abnormal immune activity. They are commonly used in severe or steroid-resistant glomerular diseases. Two important examples are cyclophosphamide and mycophenolate mofetil, often called MMF. Although both suppress the immune system, they work in very different ways. Let's begin with cyclophosphamide. Cyclophosphamide is a powerful immunosuppressive and cytotoxic agent. It has been used for many years in the treatment of immune-mediated kidney diseases. Examples include severe glomerulonephritis and certain forms of nephrotic syndrome. Cyclophosphamide belongs to a class of drugs known as alkylating agents. It works by targeting rapidly dividing cells. After activation in the liver, the drug forms reactive metabolites. These metabolites bind directly to DNA. They create cross-links between DNA strands. As a result, cells cannot replicate normally. Cell division is disrupted. Lymphocytes are particularly sensitive to this effect. Because lymphocytes drive many immune responses, their suppression reduces inflammation and immune-mediated tissue damage. This helps protect the kidneys from further injury. However, cyclophosphamide can also affect healthy cells. One major concern is bone marrow suppression. The production of white blood cells may decrease. This increases susceptibility to infection. Red blood cell and platelet production may also be affected. Regular blood count monitoring is therefore essential. Another important toxicity is hemorrhagic cystitis. Certain metabolites can irritate the bladder lining. Patients may develop bladder inflammation and bleeding. Adequate hydration helps reduce this risk. Long-term use may also increase the risk of malignancy. The bladder is particularly vulnerable. Reproductive toxicity is another concern. Cyclophosphamide may impair fertility in both men and women. These risks should be discussed before treatment begins. Now let's turn to mycophenolate mofetil. Mycophenolate mofetil has become a widely used immunosuppressive agent. It is often preferred because of its effectiveness and more favorable toxicity profile. After administration, mycophenolate mofetil is converted to its active metabolite, mycophenolic acid. This drug targets an enzyme called inosine monophosphate dehydrogenase, or IMPDH. Monophosphate dehydrogenase is essential for de novo purine synthesis. Purines are critical building blocks for DNA and RNA. Most cells can obtain purines through alternative pathways. Lymphocytes, however, depend heavily on de novo synthesis. By inhibiting monophosphate dehydrogenase, mycophenolate mofetil selectively limits lymphocyte proliferation. Fewer lymphocytes means reduced immune activity. This helps control immune-mediated kidney disease. Despite its selectivity, adverse effects can still occur. Gastrointestinal symptoms are among the most common. Patients may experience nausea, abdominal discomfort, or diarrhea. Bone marrow suppression may also develop. Leukopenia, or a low white blood cell count, is an important concern. As with other immunosuppressants, infection risk increases. Careful monitoring is required throughout treatment. Both cyclophosphamide and mycophenolate mofetil play important roles in nephrology. They help preserve kidney function by controlling harmful immune responses. Understanding their mechanisms, benefits, and toxicities is essential for safe and effective patient care. Calcineurin inhibitors are among the most important immunosuppressive drugs used in nephrology. They are commonly used when corticosteroids alone are insufficient. They are also widely used in organ transplantation. Two major drugs in this class are cyclosporine and tacrolimus. Both are highly effective at suppressing T-cell activity. Although they work through similar pathways, they bind to different intracellular proteins. Let's explore how these drugs work. The immune response depends heavily on T lymphocytes. When T cells become activated, they release signaling molecules that amplify inflammation. One of the most important of these signaling molecules is interleukin-2, or IL-2. Interleukin-2 stimulates T cell growth and proliferation. Calcineurin inhibitors interrupt this process. Cyclosporine first enters the T cell and binds to a protein called cyclophilin. Tacrolimus follows a similar strategy. However, tacrolimus binds to a different intracellular protein called FKBP12. Despite these different binding partners, both drugs ultimately affect the same target. That target is calcineurin. Calcineurin is a critical enzyme involved in T-cell activation. Under normal conditions, calcineurin activates a transcription factor called NFAT. NFAT then moves into the nucleus. Inside the nucleus, it promotes interleukin-2 gene transcription. This leads to T-cell proliferation and immune activation. Calcineurin inhibitors block this pathway. They prevent NFAT from entering the nucleus. As a result, interleukin-2 production falls dramatically. Without interleukin-2, T-cell activation is greatly reduced. The immune response becomes less aggressive. This helps control immune-mediated kidney diseases. It also helps prevent transplant rejection. Despite their effectiveness, calcineurin inhibitors have important adverse effects. One of the most significant is nephrotoxicity. Ironically, drugs used to protect the kidneys can also damage them. These medications can constrict blood vessels within the kidney. This reduces renal blood flow. Over time, kidney function may decline. Regular monitoring is therefore essential. Hypertension is another common complication. Vasoconstriction and sodium retention may contribute to elevated blood pressure. Many patients require antihypertensive therapy during treatment. Neurotoxicity can also occur. Patients may develop tremors. Headaches are common. In severe cases, confusion or seizures may occur. Cyclosporine has an additional distinctive adverse effect. It may cause gingival hyperplasia. This refers to excessive growth of gum tissue. Good dental hygiene is especially important for affected patients. A key feature of calcineurin inhibitors is their narrow therapeutic index. The difference between an effective dose and a toxic dose can be very small. For this reason, routine trough level monitoring is required. Drug concentrations must be checked regularly. Dose adjustments are often necessary. Drug interactions are also extremely important. Both cyclosporine and tacrolimus are metabolized through the CYP3A4 enzyme system. Many medications can increase or decrease their blood levels. Some antibiotics, antifungals, anticonvulsants, and even certain foods may alter drug concentrations. Failure to recognize these interactions can result in toxicity or treatment failure. For this reason, careful medication review is essential whenever calcineurin inhibitors are prescribed. When used appropriately, these drugs remain powerful tools for controlling immune-mediated kidney disease and preserving long-term renal function. Modern nephrology has entered the era of biologic therapy. Unlike traditional immunosuppressants, biologics target specific components of the immune system. This allows for more focused treatment. One of the most important biologic agents used in glomerular diseases is rituximab. Rituximab is a monoclonal antibody. Monoclonal antibodies are laboratory-designed proteins that recognize specific targets. Rituximab is designed to target a protein called CD20. CD20 is found on the surface of B lymphocytes. B cells play a major role in the immune system. They produce antibodies. They also participate in immune signaling and inflammation. In several glomerular diseases, abnormal B cell activity contributes to kidney injury. By targeting B cells, rituximab helps reduce this harmful immune response. After administration, rituximab circulates through the bloodstream. It binds specifically to CD20-positive B lymphocytes. Once attached, it marks these cells for destruction. The immune system then helps eliminate the targeted B cells. One mechanism involved is antibody-dependent cell-mediated cytotoxicity, or ADCC. In this process, immune cells recognize the antibody-coated B cells. These immune cells then release substances that destroy the targeted cells. Another mechanism is complement-dependent cytotoxicity, or CDC. Here, activation of the complement system creates membrane damage. The targeted B cells are ultimately destroyed. Together, these mechanisms produce effective B cell depletion. As B cell numbers fall, antibody production decreases. Immune-mediated inflammation also declines. This can help preserve glomerular function. Rituximab has become an important treatment option in several kidney disorders. One common use is steroid-dependent minimal change disease. Some patients relapse whenever corticosteroids are reduced. Rituximab may help maintain remission and reduce steroid exposure. It is also used in refractory focal segmental glomerulosclerosis, or FSGS. These are cases that fail to respond adequately to standard therapies. Another important indication is membranous nephropathy. In this disease, antibodies play a central role in glomerular injury. Targeting B cells can significantly improve outcomes. Although rituximab can be highly effective, it also carries important risks. Infusion reactions are among the most common adverse effects. These reactions often occur during or shortly after administration. Patients may experience fever, chills, rash, itching, or shortness of breath. Careful monitoring during infusions is essential. Premedication is often used to reduce these reactions. Because rituximab suppresses part of the immune system, infection risk increases. Both common and serious infections may occur. Patients should be monitored closely for signs of infection. Vaccination status should also be reviewed before treatment whenever possible. A rare but very serious complication is progressive multifocal leukoencephalopathy, or PML. Progressive multifocal leukoencephalopathy is caused by reactivation of the JC virus. It results in severe damage to the central nervous system. Although uncommon, it can be life-threatening. For this reason, patients receiving rituximab require careful long-term follow-up. Rituximab represents a major advance in the treatment of glomerular disorders. By selectively targeting B cells, it offers a more precise approach to immunosuppression. This targeted strategy has improved outcomes for many patients with difficult-to-treat kidney diseases. When treating glomerular diseases, controlling the immune response is important, but protecting the kidney itself is equally important. This is where angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers play a major role. These medications are considered cornerstone therapies in patients with proteinuria. Their benefits extend far beyond blood pressure control. Two commonly used examples are lisinopril and valsartan. Lisinopril belongs to the angiotensin-converting enzyme inhibitor class. Valsartan belongs to the angiotensin receptor blocker, or ARB, class. Although they work at different points in the pathway, their overall effects are very similar. To understand their benefits, we need to review the renin-angiotensin-aldosterone system. This system helps regulate blood pressure and kidney perfusion. One of its most important hormones is angiotensin II. Angiotensin II is a powerful vasoconstrictor. It narrows blood vessels throughout the body. Within the kidney, it has a particularly strong effect on the efferent arteriole. Remember that blood enters the glomerulus through the afferent arteriole. It exits through the efferent arteriole. When angiotensin II constricts the efferent arteriole, pressure inside the glomerulus increases. Initially, this helps maintain filtration. However, Over time, excessive pressure becomes harmful. The glomerular filtration barrier is exposed to chronic stress. This promotes ongoing kidney damage. It also increases protein leakage into the urine. Angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers interrupt this process. They block the actions of angiotensin II. As a result, the efferent arteriole relaxes and dilates. This is called efferent arteriolar vasodilation. The pressure inside the glomerulus falls. This reduction in intraglomerular hydrostatic pressure is extremely important. Less pressure means less mechanical injury to the filtration barrier. Protein loss in the urine decreases. This reduction in proteinuria is one of the most valuable effects of these medications. Lower proteinuria is associated with slower progression of chronic kidney disease. This is why angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers are considered renoprotective drugs. In fact, their use is recommended for most patients with significant proteinuria. Their kidney protective effect is beneficial even when blood pressure is normal. The goal is not simply to lower systemic blood pressure. The goal is also to protect the glomeruli from ongoing injury. Like all medications, angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers have adverse effects. One classic side effect of angiotensin-converting enzyme inhibitors is a persistent dry cough. This occurs because angiotensin-converting enzyme inhibition increases bradykinin levels. Some patients find the cough troublesome. In such cases, switching to an angiotensin II receptor blocker may be helpful. Another important concern is hyperkalemia. Blocking the renin-angiotensin system reduces aldosterone activity. Less aldosterone means less potassium excretion by the kidneys. Potassium levels must therefore be monitored carefully. An initial drop in glomerular filtration rate may also occur. This often reflects the desired reduction in intraglomerular pressure. A small decline is usually expected. However, a significant drop may indicate excessive renal compromise. For this reason, kidney function and serum potassium should always be checked after therapy is started or the dose is increased. When used appropriately, angiotensin-converting enzyme inhibitors and ARBs remain among the most effective tools for preserving long-term kidney function and reducing proteinuria. Edema is one of the most visible and troublesome complications of nephrotic syndrome. Patients may notice swollen ankles. Their legs may become heavy and uncomfortable. Some develop facial puffiness, especially in the morning. In severe cases, fluid can accumulate throughout the body. This widespread swelling is called anasarca. Managing edema is therefore a major treatment goal. One of the most important tools for controlling excess fluid is diuretic therapy. Diuretics are often called water pills. They help the kidneys remove excess salt and water. As fluid leaves the body, swelling gradually improves. The most commonly used diuretics for severe edema are loop diuretics. Furosemide is a classic example. Loop diuretics are powerful medications. They act on a specific part of the nephron called the thick ascending limb of the loop of Henle. This segment normally reabsorbs large amounts of sodium and chloride. Furosemide blocks a transporter known as the sodium-potassium 2-chloride cotransporter. This transporter is often abbreviated as the NKCC2 transporter. When the transporter is blocked, sodium reabsorption decreases. Chloride reabsorption also falls. Water follows these electrolytes. As a result, more fluid remains inside the tubular fluid. This excess fluid is eventually excreted as urine. The overall effect is increased urine production. Body fluid volume decreases. Edema improves. Patients often experience significant symptomatic relief. However, edema associated with nephrotic syndrome can be particularly challenging to treat. Many patients develop severe hypoalbuminemia. Albumin normally helps maintain fluid within blood vessels. When albumin levels fall, fluid shifts into the surrounding tissues. At the same time, low albumin can reduce the effectiveness of certain diuretics. This phenomenon contributes to diuretic resistance. Diuretic resistance occurs when expected fluid removal does not occur despite treatment. Patients may continue to have persistent edema. Increasing the dose of a loop diuretic may sometimes help. However, higher doses are not always sufficient. In these situations, combination therapy may be needed. Thiazide diuretics such as hydrochlorothiazide are often added. Thiazides work at a different location within the nephron. They block sodium reabsorption in the distal convoluted tubule. Using two diuretics that act at different nephron sites creates a powerful effect. This strategy is called sequential nephron blockade. By blocking sodium reabsorption at multiple points, fluid removal becomes more effective. This combination can overcome diuretic resistance in many patients. Careful monitoring is essential during treatment. Excessive diuresis can lead to dehydration. Electrolyte abnormalities may also develop. Potassium levels may fall. Blood pressure may decrease excessively. Regular assessment of body weight, fluid status, kidney function, and electrolytes is therefore important. The goal is not simply to increase urine output. The goal is to safely reduce fluid overload while preserving kidney function. When used appropriately, loop diuretics alone or in combination with thiazides remain essential therapies for managing severe and refractory edema in nephrotic syndrome. Nephrotic syndrome affects much more than the kidneys. It creates several important systemic complications. Two major concerns are severe hyperlipidemia and hypercoagulability. Both can significantly increase patient morbidity and mortality. For this reason, supportive therapies are often required alongside treatments that target the underlying kidney disease. Let's begin with hyperlipidemia. Patients with nephrotic syndrome often develop markedly elevated cholesterol levels. Triglyceride levels may also rise. This occurs because the liver tries to compensate for protein losses in the urine. As albumin levels fall, the liver increases protein production. At the same time, it increases the synthesis of lipoproteins. The result is significant dyslipidemia. Over time, elevated lipid levels contribute to atherosclerosis. This increases the risk of cardiovascular disease. Heart attacks and strokes become more likely. To reduce this risk, statin therapy is often considered. Statins are among the most widely prescribed lipid-lowering medications. They belong to a class known as HMG company enzyme reductase inhibitors. This enzyme plays a key role in cholesterol synthesis within the liver. By inhibiting MG company enzyme reductase, statins reduce cholesterol production. The liver then removes more LDL cholesterol from the bloodstream. As LDL levels decline, cardiovascular risk decreases. This is particularly important in patients with persistent nephrotic syndrome. Although statins are generally well tolerated, adverse effects can occur. One important concern is myopathy. Patients may develop muscle aches or weakness. In rare cases, severe muscle injury can occur. Liver toxicity is another potential complication. For this reason, liver function tests are often monitored during therapy. Now let's discuss hypercoagulability. Nephrotic syndrome creates a prothrombotic state. In simple terms, the blood becomes more likely to clot. This occurs through several mechanisms. One important factor is the urinary loss of antithrombin 3. Antithrombin 3 is a natural anticoagulant. Its job is to help prevent excessive clot formation. When significant amounts are lost in the urine, the body's natural defenses against thrombosis are weakened. At the same time, levels of certain clotting factors may increase. The balance shifts toward coagulation. As a result, patients become more susceptible to blood clots. Deep vein thrombosis may occur. Pulmonary embolism is another serious complication. Renal vein thrombosis is particularly associated with nephrotic syndrome. Because of this increased risk, anticoagulant therapy may be necessary in selected patients. Common anticoagulants include heparin and warfarin. These medications reduce the blood's ability to form clots. Their goal is to prevent potentially life-threatening thromboembolic events. Prophylactic anticoagulation is not required for every patient. However, it may be considered when serum albumin levels become extremely low. Risk increases significantly when albumin falls below approximately 2 to 2.5 grams per deciliter. At these levels, the hypercoagulable state becomes particularly concerning. The decision to start anticoagulation must always balance benefits and risks. Bleeding risk must be carefully evaluated. When used appropriately, statins and anticoagulants play an important supportive role in nephrotic syndrome. They help reduce cardiovascular complications, prevent thrombosis, and improve overall patient outcomes. Let's apply what we've learned to a real clinical scenario. A 45-year-old man presents to the clinic. His main complaint is severe swelling in both legs. He also reports puffiness around his eyes. The swelling has gradually worsened over several weeks. These symptoms immediately suggest significant fluid retention. The next step is to review the laboratory findings. A 24-hour urine collection shows protein excretion of 8.5 grams per day. This is far above the threshold for nephrotic syndrome. Remember, nephrotic range proteinuria is greater than 3.5 grams per day. This patient is losing enormous amounts of protein through the kidneys. His serum albumin level is only 1.9 grams per deciliter. This is profoundly low. Albumin normally helps keep fluid within blood vessels. When albumin falls, fluid leaks into surrounding tissues. This explains the severe edema and puffy eyes. His total cholesterol level is 420 milligrams per deciliter. This is markedly elevated. Hyperlipidemia is a classic feature of nephrotic syndrome. The liver increases lipoprotein production in response to protein loss. The result is severe dyslipidemia. Further evaluation confirms the diagnosis. This patient has focal segmental glomerulosclerosis, or FSGS. Focal segmental glomerulosclerosis is an important cause of nephrotic syndrome in adults. It involves scarring of portions of the glomeruli. Over time, untreated disease may lead to progressive kidney damage. Now let's build a pharmacotherapy plan. The first goal is to control the underlying glomerular disease. High-dose prednisone is often used as initial therapy. Prednisone suppresses immune-mediated injury within the glomerulus. Reducing inflammation may decrease proteinuria. It may also help preserve kidney function. The second goal is to control the edema. Loop diuretics such as furosemide are commonly prescribed. These medications increase sodium and water excretion. As excess fluid is removed, swelling gradually improves. However, severe hypoalbuminemia can make edema difficult to treat. Higher doses or combination diuretic therapy may sometimes be necessary. The third goal is kidney protection. An angiotensin-converting enzyme inhibitor is an essential component of therapy. These drugs reduce intraglomerular pressure. They decrease protein leakage through the filtration barrier. Lower proteinuria is associated with better long-term renal outcomes. The fourth goal is management of hyperlipidemia. A statin should be considered because cholesterol levels are markedly elevated. Reducing LDL cholesterol helps lower cardiovascular risk. This is particularly important in patients with chronic kidney disease. Another important consideration is thrombosis prevention. This patient's albumin level is extremely low. Severe hypoalbuminemia increases the risk of blood clots. Loss of natural anticoagulant proteins contributes to a hypercoagulable state. Venous thromboembolism becomes a significant concern. Because of this elevated risk, prophylactic anticoagulation may be considered after carefully assessing bleeding risk. This case highlights the multifaceted management of nephrotic syndrome. Successful treatment requires more than controlling proteinuria. It also involves managing edema, protecting kidney function, reducing cardiovascular risk, and preventing potentially life-threatening complications. Let's examine another important clinical case. This time, the presentation is very different from nephrotic syndrome. A 30-year-old woman arrives at the hospital with dark urine. She describes it as cola-colored. This is an important clinical clue. Dark urine often suggests the presence of blood originating from the glomeruli. She is also found to have newly developed hypertension. Her blood pressure is significantly elevated. This combination immediately raises concern for a nephritic process. The next step is to review the laboratory findings. Urinalysis reveals red blood cell casts. This is a classic sign of glomerular inflammation. Red blood cell casts form when erythrocytes become trapped within renal tubules. Their presence strongly suggests glomerulonephritis. Additional laboratory testing reveals another alarming finding. Her serum creatinine is rising rapidly. Creatinine is a marker of kidney function. A rapid increase suggests acute deterioration of glomerular filtration. This pattern indicates an aggressive disease process. The diagnosis is rapidly progressive glomerulonephritis, or RPGN. Rapidly progressive glomerulonephritis is a nephrologic emergency. Without prompt treatment, irreversible kidney failure may develop within weeks or months. The disease is characterized by severe immune-mediated injury to the glomeruli. Inflammation damages the filtration barrier. As injury progresses, kidney function declines rapidly. The primary treatment goal is to stop immune-mediated destruction as quickly as possible. Time is critical. Delays in treatment may result in permanent loss of kidney function. For this reason, high-dose intravenous corticosteroids are often initiated immediately. Methylprednisolone is commonly used. These intravenous, steroid pulses provide rapid and powerful anti-inflammatory effects. The goal is to suppress glomerular inflammation before irreversible scarring occurs. However, corticosteroids alone are often insufficient. Additional immunosuppressive therapy is usually required. Cyclophosphamide is a common option. It suppresses lymphocyte proliferation and reduces immune activity. By limiting the immune attack, further glomerular damage can be prevented. In selected patients, rituximab may be used instead. Rituximab targets CD20-positive B lymphocytes. This reduces antibody-mediated immune injury. The choice between therapies depends on the underlying cause of rapidly progressive glomerulonephritis and patient-specific factors. Another critical treatment goal is blood pressure control. Hypertension accelerates kidney damage. Elevated pressure places additional stress on already injured glomeruli. Careful blood pressure management helps protect remaining kidney function. Angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers are frequently used when appropriate. These agents provide both antihypertensive and renoprotective benefits. In some patients, calcium channel blockers may also be required. Multiple medications are sometimes necessary to achieve adequate control. Ongoing monitoring is essential throughout treatment. Kidney function must be checked regularly. Blood pressure requires close observation. Laboratory studies help assess treatment response and detect adverse effects. This case highlights the urgency of recognizing nephritic syndromes. Cola-colored urine, red blood cell casts, and rapidly rising creatinine should never be ignored. Early diagnosis and aggressive immunosuppressive therapy can be life-saving. Most importantly, prompt intervention may preserve kidney function and prevent progression to end-stage renal disease. End-stage renal disease, or ESRD, represents the final stage of chronic kidney disease. At this point, the kidneys have lost most of their functional capacity. They can no longer adequately maintain the body's internal balance. End-stage renal disease is typically defined by a glomerular filtration rate, or GFR, below 15 milliliters per minute per 1.73 square meters. This level of kidney function is critically low. The kidneys normally perform many essential tasks. They remove waste products. They regulate fluid balance. They control electrolyte levels. They maintain acid-base homeostasis. They also function as important endocrine organs. When kidney function declines to the end-stage renal disease stage, all of these processes become severely impaired. One major consequence is the accumulation of uremic toxins. Every day, the body produces metabolic waste products. Healthy kidneys continuously eliminate these substances. In end-stage renal disease, waste products begin to accumulate in the bloodstream. This condition is known as uremia. Uremic toxins affect nearly every organ system. Patients may develop fatigue and weakness. Loss of appetite is common. Nausea and vomiting may occur. Mental status changes can develop in severe cases. As toxin levels rise, overall quality of life deteriorates. Another major problem is the loss of fluid and electrolyte regulation. Healthy kidneys carefully adjust water balance. In end-stage renal disease, excess fluid cannot be effectively removed. Fluid begins to accumulate within the body. This leads to volume overload. Patients may develop leg swelling. Fluid can also collect in the lungs. Breathing becomes difficult. The cardiovascular system is placed under enormous stress. Electrolyte disturbances are equally dangerous. Hyperkalemia is one of the most feared complications. Potassium levels rise because the kidneys can no longer excrete excess potassium efficiently. Severe hyperkalemia may trigger life-threatening cardiac arrhythmias. Without prompt treatment, sudden cardiac death can occur. The kidneys also serve important endocrine functions. One example is erythropoietin production. Erythropoietin stimulates red blood cell formation in the bone marrow. In end-stage renal disease, erythropoietin production falls dramatically. As a result, anemia develops. Patients often experience fatigue, reduced exercise tolerance, and shortness of breath. Another endocrine function involves vitamin D activation. The kidneys convert vitamin D into its active form, calcitriol. In end-stage renal disease, this process becomes impaired. Calcium absorption decreases. Parathyroid hormone levels rise. Bone metabolism becomes abnormal. Over time, patients develop chronic kidney disease, mineral and bone disorder. Bones become weaker and more prone to fractures. The effects of end-stage renal disease extend far beyond the kidneys. Virtually every organ system can be affected. This is why end-stage renal disease is considered a systemic disease. Cardiovascular disease is particularly important. Patients with end-stage renal disease face a greatly increased risk of heart failure, coronary artery disease, arrhythmias, and sudden cardiac death. In fact, cardiovascular disease remains the leading cause of mortality in this population. Understanding the pathophysiology of end-stage renal disease helps explain why timely intervention is so important. As kidney function declines, complications multiply. Recognizing these changes early allows healthcare providers to initiate appropriate therapies, improve quality of life, and prepare patients for renal replacement therapy when necessary. When kidneys reach end-stage failure, they can no longer adequately remove waste products or excess fluid. At this stage, renal replacement therapy, or RRT, becomes necessary. The goal of renal replacement therapy is to replace some of the functions normally performed by healthy kidneys. Two major dialysis options are available. These are hemodialysis and peritoneal dialysis. Both therapies remove waste products and excess fluid. However, they accomplish this in very different ways. Let's begin with hemodialysis. Hemodialysis is the most commonly recognized form of dialysis. In this method, blood is removed from the body through a vascular access. The blood enters an external dialysis circuit. It then passes through a specialized filter called a dialyzer. The dialyzer is often referred to as an artificial kidney. Inside the dialyzer is a semi-permeable membrane. This membrane separates the patient's blood from a dialysis solution. Waste products move across the membrane by diffusion. Diffusion occurs when substances move from an area of higher concentration to an area of lower concentration. As blood passes through the dialyzer, toxins such as urea and creatinine move into the dialysis fluid. At the same time, excess electrolytes can also be removed. Hemodialysis also uses ultrafiltration. This process removes excess water from the bloodstream. Pressure gradients pull fluid across the membrane. The result is improved fluid balance and relief of volume overload. After filtration, the cleaned blood is returned to the patient. Most hemodialysis treatments last about 3 to 4 hours. They are commonly performed 3 times each week. Although highly effective, treatment schedules require regular visits to a dialysis center for many patients. Now let's look at peritoneal dialysis. Peritoneal dialysis uses the patient's own body as the filter. The peritoneal membrane lining the abdominal cavity serves as a natural semi-permeable membrane. A soft catheter is placed into the abdomen. Through this catheter, a special dialysis solution called dialysate is infused. The dialysate remains in the abdominal cavity for a period of time. During this dwell period, waste products move from blood vessels within the peritoneum into the dialysis fluid. Excess electrolytes are removed in the same way. Fluid removal occurs primarily through osmosis. The dialysate contains dextrose, a form of glucose. Because the dialysate has a higher osmotic concentration, water moves from the bloodstream into the abdominal cavity. This process helps remove excess fluid from the body. After the exchange is complete, the used dialysate is drained and replaced with fresh solution. Peritoneal dialysis can be performed manually throughout the day. This approach is called continuous ambulatory peritoneal dialysis. It can also be performed automatically during sleep using a cycling machine. This method is known as automated peritoneal dialysis. Both hemodialysis and peritoneal dialysis are effective forms of renal replacement therapy. Each has unique advantages and challenges. The best choice depends on medical factors, lifestyle considerations, patient preferences, and long-term treatment goals. Understanding how these therapies work helps patients make informed decisions and actively participate in their kidney care journey. Drug dosing becomes much more complicated in patients with end-stage renal disease, or ESRD. Standard doses that are safe for healthy individuals may become dangerous. This happens because kidney failure significantly alters pharmacokinetics and pharmacodynamics. In simple terms, the body handles drugs differently when the kidneys stop working properly. One of the most important changes is reduced renal clearance. Many medications are eliminated through the kidneys. Some drugs are excreted unchanged. Others are converted into active metabolites that also depend on renal excretion. When kidney function declines, these substances cannot be removed efficiently. As a result, drugs begin to accumulate in the body. Drug concentrations may rise to toxic levels. Patients become more vulnerable to adverse effects. This is why medication dosing must be adjusted carefully. One common strategy is dose reduction. A smaller dose decreases the risk of accumulation. Another strategy is interval extension. Instead of giving the drug more frequently, the time between doses is increased. The goal is to maintain therapeutic effects while avoiding toxicity. Accurate assessment of kidney function is therefore essential before prescribing many medications. However, altered drug handling in end-stage renal disease is not limited to the kidneys. Many people assume that only renal clearance is affected. In reality, non-renal drug clearance can also change. Uremic toxins accumulate as kidney function declines. These toxins do more than cause symptoms. They can interfere with drug metabolism. Some uremic toxins inhibit hepatic cytochrome P450 enzymes. These enzymes are responsible for metabolizing many medications. When enzyme activity decreases, drug breakdown slows. Blood concentrations may increase unexpectedly. Uremic toxins can also affect drug transporters. These transport proteins help move drugs into and out of cells. Changes in transporter activity may alter drug absorption, distribution, and elimination. As a result, medication responses may become less predictable. This highlights the complexity of pharmacotherapy in end-stage renal disease. Another important factor is dialysis clearance. Many patients with end-stage renal disease receive renal replacement therapy. Dialysis removes waste products from the bloodstream. However, some medications can also be removed during dialysis. The extent of removal depends on several factors. These include molecular size, protein binding, water solubility, and dialysis membrane characteristics. Some drugs are barely affected by dialysis. Others are removed very efficiently. When significant drug removal occurs, therapeutic concentrations may fall below the desired range. Treatment effectiveness may be compromised. To prevent this problem, supplemental dosing is often required. This is commonly known as post-dialysis dosing. An additional dose is administered after dialysis is completed. This restores therapeutic drug levels. Antibiotics are a classic example. Many antimicrobial agents require specific post-dialysis dosing schedules. Failure to replace the removed drug can result in treatment failure. Successful medication management in end-stage renal disease requires a thorough understanding of pharmacokinetics. Healthcare professionals must consider reduced renal clearance, altered non-renal metabolism, and dialysis-related drug removal. Careful dose adjustments improve efficacy, minimize toxicity, and help ensure optimal patient outcomes. In end-stage renal disease, prescribing the right drug is important. Prescribing the right dose is equally critical. When a patient undergoes dialysis, not every drug is removed equally. Some medications are cleared very efficiently. Others are barely affected at all. Understanding drug dialysability is essential for safe and effective dosing in patients with kidney failure. Several important factors determine whether a drug can be removed during dialysis. The first factor is molecular weight. Think of the dialysis membrane as a highly selective filter. Small molecules can pass through this filter much more easily than large molecules. In general, drugs with a molecular weight below about 500 Daltons cross dialysis membranes readily. Because they are small, they move efficiently from the bloodstream into the dialysate. As a result, these drugs may require supplemental dosing after dialysis. Larger molecules behave differently. Their size limits movement across the membrane. Many large drugs are removed slowly or not at all. Molecular size is therefore one of the first properties clinicians evaluate when assessing dialysability. The second important factor is protein binding. Many drugs circulate in the bloodstream attached to plasma proteins such as albumin. When a drug is bound to protein, it becomes too large to pass through most dialysis membranes. Only the unbound, or free, fraction can be filtered. This is a critical concept. Dialysis can only remove what is freely circulating in the blood. For example, if a drug is more than 80% protein bound, only a small portion remains available for removal. As a result, highly protein-bound drugs are generally considered poorly dialysable. Even prolonged dialysis may remove very little of the medication. The third factor is volume of distribution, often abbreviated as VD. Volume of distribution describes how extensively a drug leaves the bloodstream and enters body tissues. Some drugs remain largely within the vascular compartment. Others spread widely throughout muscles, fat, and internal organs. Drugs with a high volume of distribution spend much of their time outside the bloodstream. Since dialysis only cleans the blood, it cannot effectively remove drugs that are hidden in tissues. Even if some drug is removed from the circulation, more quickly redistributes from tissue stores. For this reason, drugs with a large volume of distribution are usually less affected by dialysis. The final major factor is water solubility. Hydrophilic drugs dissolve easily in water. Because blood and dialysate are water-based environments, these drugs move readily across dialysis membranes. As a result, hydrophilic medications are often removed efficiently during treatment. Lipophilic drugs behave differently. They tend to partition into fatty tissues and cell membranes. Less drug remains in the bloodstream. Consequently, dialysis removes them much less effectively. When determining whether post-dialysis dosing is needed, clinicians consider all of these properties together. A small, water-soluble drug with low protein binding and a low volume of distribution is highly likely to be dialyzed. A large, highly protein-bound, lipophilic drug with a high volume of distribution is far less likely to be removed. Understanding these principles helps optimize therapy, prevent toxicity, and ensure that patients receiving dialysis continue to receive effective medication treatment. When prescribing medications for dialysis patients, timing can be just as important as dose selection. A perfectly chosen drug can become ineffective if it is given at the wrong time. This is why understanding pharmacokinetic timing is so important in renal replacement therapy. One practical rule guides many dosing decisions. If a drug is significantly removed by dialysis, it should usually be administered after the dialysis session. The reason is simple. Dialysis is designed to remove substances from the bloodstream. Unfortunately, medications can be removed along with waste products. If a dialysable drug is given before treatment, a substantial portion may be cleared during dialysis. The patient may receive less drug than intended. Therapeutic concentrations may never be achieved. This can lead to treatment failure. Antibiotics provide a good example. Many antimicrobial agents are highly dialysable. For this reason, they are often administered immediately after dialysis. This ensures that the full dose remains available to exert its therapeutic effect. In some situations, supplemental post-dialysis doses are required. These replacement doses compensate for medication lost during treatment. However, drug removal is not always straightforward. Another important concept is the volume of distribution rebound phenomenon. Many drugs do not remain entirely within the bloodstream. Instead, they distribute into tissues such as muscle, fat, and organs. During dialysis, only the drug present in the blood can be removed. The drug stored in tissues remains largely untouched. As dialysis lowers blood concentrations, a concentration gradient develops. After the session ends, drug molecules begin moving back into the bloodstream. This process is called redistribution. As a result, plasma drug levels may rise again after dialysis. This increase is known as rebound. The rebound phenomenon is particularly important for drugs with large volumes of distribution. At first glance, blood concentrations may appear low immediately after dialysis. Several hours later, levels may increase as tissue stores redistribute. Understanding this process helps prevent dosing errors and unnecessary medication adjustments. Another factor influencing drug removal is dialysis membrane technology. Dialysis equipment has evolved significantly over time. Older dialysis membranes were relatively restrictive. They effectively removed small molecules but struggled to clear larger substances. Many larger drugs were therefore considered non-dialysable. Today, modern dialysis systems often use high-flux dialyzers. These advanced membranes have larger pore sizes. They allow more efficient removal of middle and larger molecular weight compounds. As a result, some medications previously believed to be poorly dialysable may now be removed more effectively. This has important clinical implications. Older dosing recommendations may not always apply to modern dialysis technology. Clinicians must consider the type of dialysis membrane being used. Drug dosing decisions should reflect current dialysis practices. Successful pharmacotherapy in dialysis patients requires careful attention to timing, dialysability, tissue redistribution, and dialysis technology. These factors work together to determine how much drug remains in the body. Understanding them helps maximize therapeutic benefit while minimizing toxicity and treatment failure. In dialysis patients, when a drug is given can be just as important as how much is given. In patients with kidney failure, drug selection becomes just as important as drug dosing. Some medications behave very differently when renal function is reduced. Antibiotics and analgesics are two of the most critical drug groups in this setting. Let's start with antibiotics. Vancomycin is a key example. It is widely used for serious gram-positive infections, but it is heavily dependent on renal clearance. That means the kidneys normally eliminate most of the drug. In end-stage renal disease, this clearance is severely reduced. Vancomycin can easily accumulate to toxic levels. It is also dialysable, meaning it can be removed during hemodialysis. This creates a dosing challenge. Too little drug leads to treatment failure. Too much drug leads to toxicity. For this reason, strict post-dialysis dosing is essential. Vancomycin levels must be carefully monitored. This is called therapeutic drug monitoring, or TDM. Regular blood level checks guide safe and effective dosing. Now let's move to pain management. Opioids require special caution in renal failure. Some opioids produce active or toxic metabolites. These metabolites depend on the kidneys for elimination. When kidney function declines, they accumulate. This can lead to serious side effects. Morphine is a classic example. It produces metabolites that can cause neurotoxicity. Patients may experience confusion, sedation, or even seizures. Meperidine is even more concerning. It produces a metabolite called normeperidine. Normeperidine is strongly neurotoxic. It can trigger tremors and seizures. For these reasons, both morphine and meperidine should generally be avoided in end-stage renal disease. Safer alternatives are available. Fentanyl is one of the preferred opioids. It is primarily metabolized by the liver. It produces inactive metabolites. This makes it much safer in renal impairment. Hydromorphone is another commonly used option. Although it has metabolites, they are less toxic and more predictable. With careful dosing, it can be used safely in end-stage renal disease patients. Close monitoring is still required. Sedation and respiratory depression must always be watched for. Now let's consider non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs are widely used for pain and inflammation. However, they are generally avoided in kidney failure. Non-steroidal anti-inflammatory drugs reduce prostaglandin synthesis. Prostaglandins help maintain renal blood flow. In healthy kidneys, this effect is usually well tolerated. But in kidney disease, prostaglandin inhibition can worsen renal perfusion. This may further damage remaining kidney function. Non-steroidal anti-inflammatory drugs also increase the risk of gastrointestinal bleeding. This risk is already higher in uremic patients. Platelet dysfunction is common in end-stage renal disease. This makes bleeding complications even more dangerous. For these reasons, non-steroidal anti-inflammatory drugs are usually contraindicated in advanced kidney disease. In summary, drug therapy in renal failure requires careful selection and dosing. Vancomycin demands strict monitoring and post-dialysis adjustment. Morphine and meperidine should be avoided due to toxic metabolites. Fentanyl and hydromorphone are safer opioid options. Non-steroidal anti-inflammatory drugs are generally avoided because of renal and bleeding risks. Safe prescribing in end-stage renal disease always balances efficacy with toxicity prevention. Understanding these principles helps protect patients and improve outcomes in complex renal care. In patients on dialysis, even routine medications require careful timing and selection. Cardiovascular drugs and vitamins are especially important in daily management. Let's start with antihypertensive therapy. Blood pressure control in dialysis patients is delicate. The timing of medication can significantly affect outcomes. If antihypertensives are taken before dialysis, they may cause intradialytic hypotension. This means the blood pressure can drop dangerously during the dialysis session. Patients may feel dizzy, weak, or even faint. In severe cases, reduced perfusion can affect the heart and brain. For this reason, many clinicians avoid giving certain blood pressure medications right before dialysis. Instead, long-acting agents are preferred. These drugs provide steady blood pressure control throughout the day. They are also less likely to be removed during dialysis. This makes their effect more predictable and safer. The goal is stable blood pressure without sudden drops during treatment. Now let's shift to an often overlooked area: vitamins. Dialysis does not only remove toxins. It can also remove essential nutrients. Water-soluble vitamins are particularly affected. These include B-complex vitamins, vitamin C, and folic acid. Because they dissolve in water, they are easily washed out during hemodialysis. Over time, patients may develop deficiencies. This can contribute to fatigue, anemia, and poor overall health. To prevent this, dialysis patients are usually prescribed specialized renal vitamins. These supplements are designed to replace what is lost during treatment. They are typically taken after dialysis sessions. Timing helps ensure optimal absorption and effectiveness. Now consider fat-soluble vitamins. These include vitamins A, D, E, and K. Unlike water-soluble vitamins, these are stored in body tissues. They are not easily removed by dialysis. In fact, they can accumulate over time in patients with kidney failure. This accumulation can become toxic. For example, excess vitamin A may cause liver toxicity and bone problems. Because of this risk, standard multivitamin preparations are often not recommended in end-stage renal disease. Instead, supplementation must be carefully tailored. Vitamin D is a special case. Kidneys normally activate vitamin D into its active form. In end-stage renal disease, this conversion is impaired. Patients often require active vitamin D analogs under medical supervision. This helps maintain calcium balance and bone health. In summary, cardiovascular and vitamin management in dialysis patients requires precision. Antihypertensives should be timed carefully to avoid hypotension during dialysis. Long-acting, non-dialyzable agents are generally preferred. Water-soluble vitamins are lost and must be replaced regularly. Fat-soluble vitamins can accumulate and may cause toxicity. Understanding these principles helps maintain safety, stability, and nutritional balance in patients undergoing long-term dialysis therapy. Anemia is one of the most common complications of end-stage renal disease. It develops slowly, but its impact is profound. The primary problem is a loss of erythropoietin production. Erythropoietin, or EPO, is a hormone made by the kidneys. It is produced by specialized peritubular fibroblasts. Erythropoietin signals the bone marrow to produce red blood cells. In end-stage renal disease, these cells are damaged or destroyed. As a result, erythropoietin levels fall dramatically. The bone marrow becomes understimulated. Red blood cell production declines. But erythropoietin deficiency is not the only cause. Uremia itself contributes to anemia. Inflammation in the body suppresses normal red cell formation. This is often called anemia of chronic disease. In addition, red blood cells do not survive as long in uremia. Their lifespan becomes shortened. They are broken down more quickly than normal. This further worsens anemia. Iron deficiency also plays a major role. Many dialysis patients lose small amounts of blood repeatedly. Blood can be lost during dialysis sessions. Frequent blood testing also contributes. Over time, iron stores become depleted. Without enough iron, hemoglobin cannot be produced effectively. The result is a combination of low production and increased loss. Clinically, anemia has wide-reaching effects. Patients often feel persistent fatigue. They may experience weakness and reduced exercise tolerance. Even simple daily activities can become exhausting. The heart is also significantly affected. To compensate for low oxygen delivery, the heart works harder. It pumps more blood to meet tissue oxygen demands. Over time, this leads to left ventricular hypertrophy. The heart muscle becomes thickened and strained. This adaptation is initially helpful but ultimately harmful. It increases the risk of heart failure and arrhythmias. Because of these effects, anemia in end-stage renal disease is closely linked to cardiovascular disease. In fact, it contributes to increased cardiovascular mortality. Managing anemia is therefore a key part of dialysis care. Treatment focuses on correcting erythropoietin deficiency. Synthetic erythropoiesis-stimulating agents are commonly used. Iron supplementation is also essential. Without adequate iron, erythropoietin therapy is less effective. The treatment goal is not to normalize hemoglobin completely. Instead, a controlled target range is used. The recommended hemoglobin level is typically between 10 and 11.5 grams per deciliter. Pushing hemoglobin too high can increase risks. Higher levels have been associated with stroke, hypertension, and vascular complications. Therefore, balance is critical. The aim is to improve symptoms and quality of life safely, not to fully normalize laboratory values. Anemia management in end-stage renal disease is a careful equilibrium. It requires understanding the underlying mechanisms. It also requires close monitoring and individualized therapy. When properly managed, patients experience improved energy, better cardiac function, and reduced cardiovascular risk. This makes anemia treatment a cornerstone of chronic kidney disease care. When treating anemia in chronic kidney disease, we go beyond just replacing blood. We target the missing hormone system behind red blood cell production. That is where erythropoiesis-stimulating agents, or ESAs, come in. Common examples include epoetin alpha and darbepoetin alpha. These are synthetic versions of erythropoietin. They replace the hormone that failing kidneys can no longer produce. Normally, erythropoietin is made in the kidneys. It signals the bone marrow to produce red blood cells. In end-stage renal disease, this signal is lost, so the bone marrow becomes underactive. Erythropoiesis-stimulating agents restore that signal. They bind to receptors on erythroid progenitor cells in the bone marrow. This stimulates red blood cell production. Hemoglobin levels begin to rise gradually. But erythropoiesis-stimulating agent therapy is not simple or risk-free. One major adverse effect is hypertension. Blood viscosity increases as hemoglobin rises. Vascular resistance may also increase. This can elevate blood pressure in susceptible patients. Another important risk is thrombosis. Higher red cell mass increases blood thickness. This can predispose to clot formation. Careful dosing is therefore essential. We do not aim for normal hemoglobin levels. We aim for safe, moderate correction. Now let's talk about iron. Iron is not optional in erythropoiesis-stimulating agent therapy. It is a prerequisite for effectiveness. Without iron, new red blood cells cannot be formed properly. Even if erythropoiesis-stimulating agents are given, response will be poor. This is why iron status must always be assessed. In dialysis patients, iron deficiency is very common. Several mechanisms contribute. Blood loss during dialysis sessions is one factor. Frequent laboratory testing also removes small amounts of blood. Chronic inflammation reduces iron availability. This leads to functional iron deficiency. For this reason, iron supplementation is essential. In hemodialysis patients, intravenous iron is preferred. IV iron bypasses the gastrointestinal system. Uremia often reduces oral iron absorption. Inflammation also limits intestinal uptake. So IV iron ensures more reliable correction of deficiency. Iron therapy enhances the response to erythropoiesis-stimulating agents. It improves hemoglobin production efficiency. It also allows lower erythropoiesis-stimulating agent doses to be used. This reduces the risk of adverse effects. Monitoring is a key part of therapy. We track ferritin levels and transferrin saturation. Ferritin reflects iron stores. Transferrin saturation, or TSAT, reflects iron availability. Target ferritin is usually above 200 nanograms per milliliter. Target transferrin saturation is typically above 20%. These targets ensure sufficient iron for erythropoiesis. But they also avoid iron overload. Excess iron can promote oxidative stress and infection risk. So balance is critical. Erythropoiesis stimulating agent and iron therapy work together. One provides the signal for red blood cell production. The other provides the raw material. When both are optimized, anemia improves significantly. Patients experience better energy, improved exercise tolerance, and reduced cardiac strain. This combined approach is a cornerstone of modern renal anemia management. CKD mineral and bone disorder is one of the most complex complications of end-stage renal disease. It is not just a bone problem. It is a full-body disruption of mineral balance. It affects calcium, phosphate, vitamin D, and parathyroid hormone. Let's break it down step by step. In healthy kidneys, phosphate is filtered and excreted efficiently. But in end-stage renal disease, this process fails. Phosphate begins to accumulate in the blood. This condition is called hyperphosphatemia. High phosphate levels become toxic over time. At the same time, another key process is disrupted. Healthy kidneys activate vitamin D into its active form, calcitriol. Calcitriol is essential for calcium absorption from the gut. In end-stage renal disease, this activation step is reduced. So even if dietary calcium is adequate, absorption drops. This leads to hypercalcemia. Now we have two major imbalances: high phosphate and low calcium. This combination is highly stimulatory to the parathyroid glands. The parathyroid glands constantly monitor calcium levels. When calcium falls, they respond by increasing hormone secretion. This hormone is called parathyroid hormone, or PTH. So in CKD, parathyroid hormone levels begin to rise persistently. This condition is known as secondary hyperparathyroidism. At first, this is a compensatory response. The body is trying to restore calcium balance. Parathyroid hormone tries to increase calcium by pulling it from bones. It also tries to increase phosphate excretion. But in end-stage renal disease, the kidneys cannot respond properly. So the cycle continues unchecked. Phosphate remains high. Calcium remains low. Parathyroid hormone continues to rise. Over time, this chronic stimulation becomes harmful. Bone structure begins to break down. This process is called renal osteodystrophy. Bones become weak and demineralized. Patients are at higher risk of fractures. Bone pain may also develop. But the effects are not limited to bones. Calcium and phosphate can deposit in soft tissues. This leads to vascular and vascular wall calcification. Blood vessels become stiff and less compliant. This significantly increases cardiovascular risk. In fact, CKD mineral and bone disorder is strongly linked to heart disease in end-stage renal disease patients. The system becomes a vicious cycle. Kidney failure drives mineral imbalance. Mineral imbalance drives hormone dysregulation. Hormone dysregulation drives bone and vascular damage. Understanding this cascade is essential in renal medicine. Management focuses on breaking the cycle. This includes controlling phosphate intake and absorption. It also involves vitamin D replacement and parathyroid hormone regulation. Sometimes phosphate binders are used. Active vitamin D analogues may also be prescribed. In severe cases, parathyroid suppression therapy is needed. The goal is to protect both bone health and cardiovascular stability. CKD mineral and bone disorder shows how kidney failure affects far more than filtration. It is a systemic disease of mineral and hormonal imbalance. In chronic kidney disease, mineral and bone disorder, controlling phosphate is a key treatment goal. Because when phosphate rises, the whole mineral balance shifts. Calcium drops, parathyroid hormone rises, and bone disease progresses. So one of the first lines of therapy is phosphate binders. These are medications that act inside the gut. They do not work in the bloodstream. Their job is simple but powerful. They bind dietary phosphate before it is absorbed. Then the phosphate is eliminated in stool. But timing is critical. They must be taken with meals. If taken on an empty stomach, they do very little. Now let's look at calcium-based phosphate binders. Common examples include calcium acetate and calcium carbonate. These drugs bind phosphate effectively in the intestines. They reduce phosphate absorption and help lower serum phosphate. But they come with an important caution. They also add extra calcium into the body. In some patients, this can push calcium levels too high, and excess calcium can deposit in blood vessels. This increases the risk of vascular calcification. So we use them carefully, especially in patients already prone to high calcium. Now let's shift to non-calcium phosphate binders. These are often preferred in many end-stage renal disease patients. One example is sevelamer. Another is lanthanum carbonate. These agents bind phosphate without adding calcium. So they help control phosphate while avoiding calcium overload. This makes them especially useful in patients with vascular calcification risk. They also help reduce progression of chronic kidney disease, mineral and bone disorder complications. However, they are not completely free of side effects. Gastrointestinal symptoms are the most common. Patients may experience bloating, nausea, or abdominal discomfort. Constipation is also frequently reported. Despite these effects, they are generally well tolerated. The overall strategy in chronic kidney disease, mineral and bone disorder is balance. We want to lower phosphate. We want to avoid excessive calcium. And we want to reduce parathyroid stimulation. Phosphate binders play a central role in achieving this balance. They are most effective when combined with dietary phosphate restriction, and when used consistently with every meal. Missed doses can lead to poor phosphate control. Over time, good phosphate control helps stabilize parathyroid hormone levels. It also helps protect bone structure, and it reduces vascular calcification risk. So phosphate binders are not just supportive therapy. They are a cornerstone of chronic kidney disease, mineral and bone disorder management. They help interrupt the cycle of mineral imbalance, and they contribute to long-term cardiovascular and skeletal protection in end-stage renal disease patients. In chronic kidney disease, mineral and bone disorder, controlling phosphate is only part of the story. The other major target is parathyroid hormone, or PTH. When parathyroid hormone stays high for too long, bone and vascular damage accelerate. So pharmacotherapy often focuses on suppressing parathyroid hormone directly. One important class of drugs is active vitamin D analogs. These include calcitriol and paracalcitol. They are used when the kidney can no longer activate vitamin D on its own. In healthy kidneys, vitamin D helps regulate calcium and phosphate balance. But in end-stage renal disease, this activation step is lost. So we replace it with active forms. These drugs bind to vitamin D receptors in many tissues. But one key target is the parathyroid gland. When they activate these receptors, they reduce parathyroid hormone gene expression. In simple terms, they tell the parathyroid gland to slow down parathyroid hormone production. As parathyroid hormone levels fall, bone turnover becomes more controlled. However, there is a trade-off. Active vitamin D increases calcium absorption from the gut. It can also increase phosphate absorption. So while parathyroid hormone decreases, calcium and phosphate may rise. This can worsen vascular calcification if not monitored carefully. Because of this, dosing must be balanced and individualized. Now let's look at a newer and very important drug class. These are calcimimetics. The key example is cinacalcet. Calcimimetics work in a completely different way. Instead of adding vitamin D activity, they target calcium sensing. They act on the calcium sensing receptor, or CASR. This receptor is located on the parathyroid gland. It normally detects blood calcium levels. When calcium is low, it triggers parathyroid hormone release. Cinacalcet changes how this receptor behaves. It makes the receptor more sensitive to existing calcium. This is called allosteric sensitization. So even normal calcium levels are perceived as higher. As a result, the parathyroid gland reduces parathyroid hormone secretion. This happens without actually increasing serum calcium. That is a major advantage. Because it lowers parathyroid hormone without raising calcium or phosphate levels. This helps avoid worsening vascular calcification. It also helps stabilize mineral balance more safely in end-stage renal disease patients. However, calcimimetics also have side effects. The most common is hypercalcemia. Because parathyroid hormone is suppressed, calcium levels can drop. Some patients may also experience nausea or gastrointestinal discomfort. Despite this, they are very effective in difficult cases of secondary hyperparathyroidism. In clinical practice, both active vitamin D analogues and calcimimetics are often used together. They target parathyroid hormone from different angles. Vitamin D analogues reduce parathyroid hormone gene expression. Calcimimetics reduce parathyroid hormone secretion sensitivity. This dual approach provides better control of chronic kidney disease, mineral and bone disorder. The ultimate goal is not just lowering lab numbers. It is preventing bone disease, vascular calcification, and cardiovascular complications. Controlling parathyroid hormone is therefore a central pillar of chronic kidney disease, mineral and bone disorder management. And careful drug selection helps balance efficacy with safety in end-stage renal disease patients. Complications of end-stage renal disease can become life-threatening. One of the most dangerous complications is hyperkalemia. This means there is too much potassium in the blood. Healthy kidneys remove excess potassium every day. In end-stage renal disease, the kidneys lose this ability completely. Potassium begins to accumulate in the body. Even a small increase can be dangerous. High potassium affects the electrical activity of the heart. It can trigger severe arrhythmias. These abnormal heart rhythms may cause cardiac arrest and sudden death. Because of this, hyperkalemia is considered a medical emergency. Long-term control focuses on reducing potassium levels and preventing recurrent episodes. Potassium binders are commonly used for chronic management. These medicines work inside the gastrointestinal tract. They bind potassium and help remove it through the stool. Sodium polystyrene sulfonate, also called SPS, is one of the older potassium binders. It exchanges sodium for potassium in the gut. Although effective, it has been linked to serious gastrointestinal complications. In rare cases, bowel necrosis can occur. Newer agents have improved safety profiles. Patiromer and sodium zirconium cyclosilicate, often called SZC, are now widely used for daily potassium control. These drugs provide more predictable potassium reduction and are generally better tolerated. When potassium rises to dangerous levels, emergency treatment must begin immediately. The first priority is protecting the heart. Intravenous calcium gluconate stabilizes the cardiac cell membrane. It does not lower potassium levels, but it reduces the risk of fatal arrhythmias. Next, potassium must be shifted from the bloodstream into the cells. Insulin combined with glucose is highly effective for this purpose. Insulin drives potassium into cells, while glucose prevents hypoglycemia. Nebulized albuterol can also help. By stimulating beta-2 receptors, it promotes intracellular movement of potassium. This provides an additional temporary reduction in serum potassium levels. These measures only buy time. They do not remove potassium from the body. In patients with end-stage renal disease, dialysis remains the definitive treatment. Hemodialysis rapidly eliminates excess potassium from the bloodstream and provides the most effective therapy for severe hyperkalemia. Early recognition is critical. Continuous monitoring and prompt treatment can prevent catastrophic cardiac complications. In patients with end-stage renal disease, managing potassium levels is essential for survival. Hyponatremia is one of the most common electrolyte disorders encountered in clinical practice. It occurs when the serum sodium concentration falls below 135 milliequivalents per liter. Although sodium levels appear low, the problem is usually not a true lack of sodium. In most cases, hyponatremia is actually a disorder of water balance. The key concept to remember is that excess water dilutes the sodium already present in the body. In other words, patients are often carrying too much water rather than too little sodium. Understanding this principle is essential because treatment depends on identifying the underlying cause. Hyponatremia is classified according to the patient's volume status. This approach helps clinicians determine why sodium levels have fallen and guides appropriate therapy. The first category is hypovolemic hyponatremia. In this condition, both sodium and water are lost from the body. However, sodium loss exceeds water loss. Common causes include excessive diuretic use, prolonged vomiting, and severe diarrhea. Patients may present with dehydration, low blood pressure, dizziness, and tachycardia. The second category is euvolemic hyponatremia. In these patients, total body sodium remains relatively normal, but excess free water is retained. One of the most important causes is the syndrome of inappropriate antidiuretic hormone secretion, or SIADH. Increased antidiuretic hormone causes the kidneys to retain water, leading to dilution of serum sodium. Despite the water retention, patients often appear clinically normal without obvious signs of dehydration or fluid overload. The third category is hypovolemic hyponatremia. In this situation, both sodium and water are increased, but water accumulation is much greater. The excess fluid dilutes serum sodium concentrations. Conditions associated with fluid overload commonly produce this pattern. These include congestive heart failure, liver cirrhosis, and end-stage renal disease. Recognizing volume status is one of the most important steps in evaluating hyponatremia. The same laboratory value can represent very different underlying disorders. Therefore, successful treatment requires correcting the imbalance responsible for the excess or deficient body water. Hyponatremia should never be viewed simply as a sodium problem. It is primarily a water problem. Understanding this concept allows clinicians to diagnose the cause accurately and choose the most effective therapy for each patient. A 60-year-old man with end-stage renal disease is receiving regular hemodialysis. He presents with persistent fatigue and worsening bone pain. These symptoms suggest multiple complications of chronic kidney disease. Laboratory results provide important clues. His hemoglobin is 8.9 grams per deciliter, confirming significant anemia. His phosphate level is markedly elevated at 7.2 milligrams per deciliter. Serum calcium is low at 8 mg per deciliter. Parathyroid hormone levels are extremely high at 950 picograms per milliliter. Ferritin is 350, indicating that iron stores are adequate. This combination of findings points to two major diagnoses. The first is anemia of chronic kidney disease. The second is severe chronic kidney disease mineral and bone disorder, also known as CKD-MBD. The patient's fatigue is most likely related to anemia. Diseased kidneys produce insufficient erythropoietin, the hormone responsible for stimulating red blood cell production. As a result, hemoglobin levels gradually decline. Since ferritin levels demonstrate adequate iron reserves, additional iron supplementation is not immediately required. Instead, intravenous epoetin alpha should be initiated. This erythropoiesis-stimulating agent replaces the missing hormone and promotes red blood cell formation. Over time, hemoglobin levels should improve, leading to increased energy and better quality of life. The patient's bone pain is explained by severe disturbances in mineral metabolism. Elevated phosphate levels are common in end-stage renal disease because damaged kidneys cannot eliminate phosphate effectively. Hyperphosphatemia stimulates excessive secretion of parathyroid hormone, producing secondary hyperparathyroidism and progressive bone disease. Controlling phosphate is therefore a major therapeutic goal. Sevelamer should be started and taken with meals. This phosphate binder acts within the gastrointestinal tract and prevents dietary phosphate absorption. Lower phosphate levels help slow the progression of chronic kidney disease-related bone complications. Parathyroid hormone levels are profoundly elevated, indicating severe secondary hyperparathyroidism. However, calcium levels are already low and phosphate levels remain high. Under these circumstances, cinacalcet represents an appropriate therapeutic choice. Cinacalcet increases the sensitivity of calcium-sensing receptors on the parathyroid glands. This suppresses parathyroid hormone secretion without increasing calcium or phosphate levels. It provides a safer approach in patients with low serum calcium and persistent hyperphosphatemia. This case highlights how multiple complications of end-stage renal disease often occur simultaneously. Successful management requires a comprehensive approach. Treating anemia improves oxygen delivery and reduces fatigue. Controlling phosphate and suppressing excessive parathyroid hormone help protect the skeleton and reduce long-term complications. Careful interpretation of laboratory values allows clinicians to individualize therapy and optimize outcomes in patients receiving hemodialysis. A 55-year-old woman with end-stage renal disease is receiving maintenance hemodialysis 3 times weekly on a Monday, Wednesday, and Friday schedule. She is admitted to the hospital with methicillin-resistant Staphylococcus aureus, or MRSA, bacteremia. Because methicillin-resistant Staphylococcus aureus bloodstream infections are serious and potentially life-threatening, prompt antibiotic therapy is essential. Intravenous vancomycin is selected as the treatment of choice. However, dosing vancomycin in patients receiving hemodialysis requires careful attention to pharmacokinetic principles. Normally, the kidneys play a major role in eliminating vancomycin from the body. In patients with kidney failure, this natural clearance is severely reduced. At the same time, modern high-flux dialysis membranes can remove substantial amounts of the drug during dialysis sessions. Vancomycin possesses several characteristics that make it readily dialysable. It is primarily water-soluble and has relatively low protein binding. Because much of the drug remains in the bloodstream rather than being tightly bound to proteins, hemodialysis can efficiently remove it from circulation. Treatment begins with an appropriate loading dose. The loading dose should be calculated using the patient's actual body weight. This initial dose rapidly achieves therapeutic concentrations and ensures adequate bacterial killing during the early phase of infection. After the loading dose, maintenance therapy must be individualized according to the patient's dialysis schedule. Since significant amounts of vancomycin are removed during each hemodialysis session, supplemental doses are typically administered after dialysis has been completed. Giving the dose after treatment prevents premature drug removal and helps maintain effective serum concentrations. Therapeutic drug monitoring is a critical component of vancomycin therapy. Blood samples for vancomycin trough concentrations should be obtained immediately before the next hemodialysis session begins. These pre-dialysis levels provide valuable information about the patient's drug exposure and help clinicians adjust subsequent doses appropriately. Monitoring serum concentrations is especially important because both underdosing and overdosing carry significant risks. Inadequate drug levels may lead to persistent bacteremia, treatment failure, and the development of antimicrobial resistance. Excessive concentrations increase the risk of toxicity and unnecessary drug accumulation. This case illustrates the importance of understanding pharmacokinetics in patients receiving dialysis. Drug properties, dialysis schedules, and serum drug monitoring all influence dosing decisions. Successful management requires coordination between physicians, nephrologists, pharmacists, and dialysis staff. In patients with end-stage renal disease, antibiotic therapy is not simply about choosing the correct drug. It is also about delivering the right dose at the right time. Careful adjustment based on dialysis and therapeutic monitoring helps maximize efficacy while minimizing toxicity. Glomerular disorders are among the most important causes of chronic kidney disease. Understanding the difference between nephrotic and nephritic syndromes is essential because their clinical features and treatment strategies are very different. A useful way to remember nephrotic syndrome is to think of a damaged and excessively leaky sieve. The glomerular filtration barrier loses its ability to retain proteins. Large amounts of protein escape into the urine. This leads to hypoalbuminemia, generalized edema, and elevated blood lipid levels. Patients often present with swollen legs, facial puffiness, and frothy urine. Nephritic syndrome is different. Here, inflammation within the glomerulus is the dominant problem. The injured capillaries allow red blood cells to enter the urine. Patients commonly develop hematuria, hypertension, and reduced kidney function. Instead of massive protein loss, the hallmark feature is inflammatory damage. Many glomerular diseases are driven by abnormal immune responses. For this reason, immunosuppressive therapy forms the foundation of treatment. Corticosteroids are often considered first-line agents. They reduce inflammation and suppress harmful immune activity directed against the kidneys. Many patients with minimal change disease and several other glomerular disorders respond well to steroid therapy. When steroid therapy alone is insufficient, additional immunosuppressive agents may be required. Calcineurin inhibitors such as cyclosporine and tacrolimus suppress T-cell activation and help reduce ongoing glomerular injury. Cyclophosphamide provides more potent immunosuppression and is used in selected severe diseases. Rituximab targets CD20-positive B lymphocytes and has become an important option for resistant or relapsing conditions. Regardless of the underlying diagnosis, protecting kidney function remains a major therapeutic goal. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are considered essential in patients with significant proteinuria. These medications lower intraglomerular pressure and reduce urinary protein loss. Long-term use helps slow the progression of chronic kidney disease. Supportive treatment is equally important. Loop diuretics are frequently prescribed to control edema and improve symptoms related to fluid retention. Reduction of excess fluid can significantly enhance patient comfort and quality of life. Hyperlipidemia commonly accompanies nephrotic syndrome. Statins are often used to lower cholesterol levels and reduce cardiovascular risk. Since cardiovascular disease is a major cause of morbidity in kidney patients, lipid management is an important component of care. Patients with severe nephrotic syndrome also have an increased tendency to form blood clots. Loss of anticoagulant proteins in the urine contributes to this hypercoagulable state. In selected high-risk patients, anticoagulant therapy may be considered to prevent thromboembolic complications. Successful management of glomerular disorders requires both disease-specific therapy and comprehensive supportive care. By controlling immune injury, reducing proteinuria, and managing complications, clinicians can preserve kidney function and improve long-term outcomes. End-stage renal disease represents the final stage of chronic kidney disease. At this point, the kidneys can no longer maintain normal body functions. Waste products, excess fluid, and electrolytes begin to accumulate. Without treatment, survival is impossible. Renal replacement therapy becomes essential. The two main options are hemodialysis and peritoneal dialysis. Both methods remove toxins and excess fluid when the kidneys have completely failed. Although dialysis prolongs life, it cannot fully replace all normal kidney functions. Drug therapy in patients with end-stage renal disease requires special attention. Many medications depend on the kidneys for elimination. Loss of renal clearance can lead to dangerous drug accumulation if doses are not adjusted appropriately. Clinicians must also consider whether a medication is removed by dialysis. Several pharmacokinetic factors influence drug dialysability. These include molecular weight, protein binding, and volume of distribution. Water-soluble drugs with low protein binding are generally removed more easily during dialysis sessions. Anemia is one of the most common complications of advanced kidney disease. Diseased kidneys produce inadequate amounts of erythropoietin, resulting in reduced red blood cell production. Patients often experience fatigue, weakness, and reduced exercise tolerance. Management focuses on restoring hemoglobin levels and improving quality of life. Erythropoiesis-stimulating agents, or ESAs, replace the missing erythropoietin signal and stimulate bone marrow activity. Adequate iron stores are equally important for successful treatment. Intravenous iron therapy is frequently required because oral iron is often insufficient in dialysis patients. The usual hemoglobin target ranges from 10 to 11.5 grams per deciliter. Chronic kidney disease also disrupts mineral and bone metabolism. Impaired phosphate excretion leads to hyperphosphatemia. Elevated phosphate stimulates excessive secretion of parathyroid hormone and contributes to secondary hyperparathyroidism. Controlling phosphate is a major therapeutic priority. Phosphate binders should be taken with meals to prevent intestinal phosphate absorption. Maintaining lower phosphate levels helps protect bones and reduce long-term complications. Suppression of parathyroid hormone is another important goal. Active vitamin D preparations reduce parathyroid hormone production and improve calcium balance. In selected patients, cinacalcet increases the sensitivity of calcium sensing receptors and safely lowers parathyroid hormone levels without causing excessive calcium or phosphate elevations. Hyperkalemia remains one of the most dangerous complications of end-stage renal disease. Elevated potassium levels can trigger fatal cardiac arrhythmias and require immediate treatment. In emergency situations, insulin combined with glucose rapidly shifts potassium from the bloodstream into cells. This provides temporary protection but does not eliminate potassium from the body. For long-term management, newer potassium binders such as patiromer and sodium zirconium cyclosilicate provide effective daily potassium control and help prevent recurrent episodes. Successful management of end-stage renal disease requires more than dialysis alone. Careful pharmacotherapy and aggressive management of complications are essential for improving survival and preserving quality of life. Let's test an important pharmacokinetic principle in dialysis patients. The question asks which drug property significantly decreases the likelihood that a drug will be removed by hemodialysis. The correct answer is C, high protein binding, greater than 90%. To understand why, think about what happens during hemodialysis. Blood flows through a dialysis membrane, and only substances that are freely circulating in the plasma can cross that membrane efficiently. When a drug is highly protein-bound, most of the drug molecules are attached to plasma proteins, especially albumin. These protein drug complexes are too large to pass through the dialysis membrane. As a result, only a very small fraction of the drug remains free and available for removal. Imagine a drug that is 95% protein-bound. Only 5% of the drug is circulating freely in the bloodstream. Hemodialysis can only remove that small free fraction. Therefore, overall drug clearance during dialysis is minimal. Now let's look at the other options. Low molecular weight generally increases dialysability. Small molecules move across dialysis membranes much more easily than large molecules. High water solubility also favors dialysis removal. Water-soluble drugs remain in the bloodstream and are more accessible to the dialysis process. A low volume of distribution increases dialysability as well. Drugs with a low volume of distribution stay primarily within the vascular compartment, where dialysis can reach them. In contrast, drugs with a large volume of distribution are extensively distributed into tissues and are less available for removal. A simple way to remember this is that dialysis works best on drugs that are small, water-soluble, poorly protein-bound, and confined mainly to the bloodstream. On the other hand, drugs that are highly protein-bound, very large, or extensively distributed into tissues are generally poor candidates for dialysis removal. This concept is critical when dosing medications in patients receiving renal replacement therapy. Failure to account for protein binding and other pharmacokinetic properties can lead to underdosing, overdosing, or inappropriate dose adjustments. So the key takeaway is simple. High protein binding acts like a protective shield, preventing many drug molecules from crossing the dialysis membrane. That is why option C is the correct answer. It's time for another knowledge check in glomerular disease pharmacotherapy. The question asks which medication is considered the standard first-line treatment for inducing remission in primary nephrotic syndromes such as minimal change disease. The correct answer is B, oral prednisone. Corticosteroids remain the cornerstone of therapy for most patients with primary nephrotic syndrome. Among these agents, oral prednisone is the traditional first-line choice and has been used successfully for decades. Minimal change disease is an immune-mediated disorder that causes injury to the podocytes, leading to massive protein loss in the urine. Fortunately, this condition is highly responsive to corticosteroids. Prednisone works by suppressing abnormal immune activity and reducing inflammation within the glomerulus. As the immune attack subsides, the glomerular filtration barrier begins to recover. Proteinuria gradually decreases, serum albumin levels improve, and edema resolves. Many patients, especially children, achieve complete remission after several weeks of treatment. Because of this excellent response rate, corticosteroids are considered the initial therapy of choice. Now let's examine the other options. Rituximab is a monoclonal antibody directed against CD20-positive B lymphocytes. It is generally reserved for patients with frequent relapses, steroid dependence, or steroid-resistant disease. It is not usually the first medication prescribed. Cyclophosphamide is a potent immunosuppressive agent. It may be used in difficult or recurrent cases, but its potential toxicities limit routine first-line use. Tacrolimus, a calcineurin inhibitor, can also induce remission in certain nephrotic syndromes. However, it is typically reserved for patients who cannot tolerate corticosteroids or who fail to respond adequately to initial therapy. A simple way to remember this concept is that treatment usually starts with steroids first, followed by alternative immunosuppressive agents only when necessary. The goal of therapy is to achieve remission, reduce proteinuria, preserve kidney function, and prevent disease progression. Although supportive treatments such as angiotensin-converting enzyme inhibitors, diuretics, and statins are important, they do not address the underlying immune process. Prednisone targets the disease mechanism itself and therefore remains the standard first-line pharmacological agent. So the key takeaway is straightforward. In primary nephrotic syndromes, especially minimal change disease, oral prednisone is the standard first-line therapy for inducing remission. Therefore, the correct answer is option B, oral prednisone. Here is another important knowledge check from chronic kidney disease pharmacotherapy. The question asks which medication works by allosterically increasing the sensitivity of the calcium sensing receptor, or CASR, on the parathyroid gland. The correct answer is C, cinacalcet. Cinacalcet belongs to a class of drugs known as calcimimetics. These agents do not supply calcium directly. Instead, they make the parathyroid gland more sensitive to the calcium already present in the bloodstream. Under normal conditions, calcium-sensing receptors on parathyroid cells monitor serum calcium concentrations. When calcium levels fall, the glands respond by releasing parathyroid hormone, or PTH. In chronic kidney disease, persistent phosphate retention and disturbances in calcium metabolism cause excessive parathyroid hormone secretion. This leads to secondary hyperparathyroidism. Cinacalcet binds allosterically to the calcium-sensing receptor. This means it attaches to a different site than calcium itself. By altering receptor configuration, the drug enhances the receptor's response to circulating calcium. As a result, the parathyroid gland perceives calcium levels as being higher than they actually are. This suppresses parathyroid hormone secretion and helps control secondary hyperparathyroidism. Cinacalcet is especially useful in dialysis patients with severe elevations in parathyroid hormone accompanied by hyperphosphatemia. Because it lowers parathyroid hormone without increasing phosphate levels, it provides an advantage in patients where additional calcium or vitamin D therapy may worsen mineral imbalance. Now let's review the other options. Calcitriol is the active form of vitamin D. It suppresses parathyroid hormone synthesis by acting on vitamin D receptors within the parathyroid gland. However, it does not increase calcium sensing receptor sensitivity. Sevelamer is a phosphate binder. It works inside the gastrointestinal tract and prevents dietary phosphate absorption. Its mechanism is unrelated to the calcium sensing receptor. Calcium acetate is another phosphate binder. In addition to binding phosphate, it provides supplemental calcium. However, it does not directly modify receptor sensitivity on the parathyroid gland. A simple way to remember this concept is that cinacalcet tricks the parathyroid gland into believing calcium levels are higher than they really are. This mechanism reduces excessive parathyroid hormone secretion and helps protect against the bone disease associated with chronic kidney disease, mineral and bone disorder. Therefore, the key takeaway is clear. The medication that allosterically increases calcium sensing receptor sensitivity is cinacalcet. So the correct answer is option C, cinacalcet. Here is another important knowledge check in the management of end-stage renal disease. The question asks about the established hemoglobin target for patients with end-stage renal disease who are receiving erythropoiesis-stimulating agents, also known as ESAs. The correct answer is B, 10 to 11.5 grams per deciliter. Anemia is a common complication of advanced kidney disease. Healthy kidneys normally produce erythropoietin, a hormone that stimulates the bone marrow to produce red blood cells. As kidney function declines, erythropoietin production decreases, leading to progressive anemia. Patients often experience fatigue, weakness, shortness of breath, and reduced exercise capacity. To correct this problem, erythropoiesis-stimulating agents such as epoetin alpha and darbepoetin alpha are commonly prescribed. The goal of treatment is not to restore hemoglobin to completely normal levels. Instead, therapy aims to improve symptoms while minimizing complications associated with excessive hemoglobin correction. Current practice targets a hemoglobin range of approximately 10 to 11.5 grams per deciliter. This range provides adequate oxygen carrying capacity for most patients and improves quality of life without exposing them to unnecessary risk. Many people assume that achieving normal hemoglobin values is always beneficial. However, studies have shown that aggressively increasing hemoglobin to levels seen in healthy individuals can be harmful in patients with chronic kidney disease. Higher hemoglobin targets have been associated with increased risks of hypertension, vascular access thrombosis, stroke, myocardial infarction, and other cardiovascular events. For this reason, hemoglobin concentrations above 13 grams per deciliter are generally avoided during erythropoiesis-stimulating agent therapy. Now let's review the other options. A hemoglobin range of 8 to 9 grams per deciliter represents significant anemia. Patients within this range often remain symptomatic and may have impaired functional capacity. Levels between 12 and 13.5 grams per deciliter are higher than the recommended therapeutic target for most dialysis patients. Pushing hemoglobin to these values may increase cardiovascular risk. A hemoglobin concentration above 14 grams per deciliter reflects the normal range for healthy individuals, but this is not the desired target in patients receiving erythropoiesis-stimulating agents for end-stage renal disease-related anemia. Successful anemia management also requires adequate iron stores. Intravenous iron supplementation is frequently necessary because erythropoiesis cannot occur efficiently without sufficient iron availability. A simple way to remember this concept is that erythropoiesis-stimulating agent therapy aims for a safe middle ground. The objective is not perfect normalization, but balanced correction. Therefore, the key takeaway is clear. Patients with end-stage renal disease receiving erythropoiesis-stimulating agents should generally maintain a hemoglobin target between 10 and 11.5 grams per deciliter. So the correct answer is option B, 10 to 11.5 grams per deciliter. Here is another important knowledge check in electrolyte disorders. The question asks which condition is most commonly associated with severe hyponatremia in a patient who appears euvolemic. In other words, the patient has normal total body sodium and no obvious signs of dehydration or fluid overload. The correct answer is B, syndrome of inappropriate antidiuretic hormone secretion, or SIADH. Hyponatremia is defined as a serum sodium concentration below 135 milliequivalents per liter. One of the most important concepts to remember is that hyponatremia is usually a disorder of water balance rather than a true sodium deficiency. In syndrome of inappropriate antidiuretic hormone, excessive amounts of antidiuretic hormone, also called ADH, are released despite normal or low plasma osmolality. Antidiuretic hormone acts on the kidneys and promotes water reabsorption. As more water is retained, the sodium already present in the body becomes diluted. Although total body water increases slightly, the excess is usually not large enough to produce visible edema. Therefore, patients often appear clinically normal. They are neither dehydrated nor overloaded with fluid. This is why syndrome of inappropriate antidiuretic hormone is classified as euvolemic hyponatremia. Common causes of syndrome of inappropriate antidiuretic hormone include pulmonary disease, central nervous system disorders, malignancies, and certain medications. Regardless of the cause, the underlying mechanism remains inappropriate water retention. Now let's examine the other options. Dehydration and prolonged vomiting typically cause hypovolemic hyponatremia. In these situations, both sodium and water are lost, but sodium loss exceeds water loss. Patients usually show signs of volume depletion such as hypotension and dry mucous membranes. Congestive heart failure causes hypovolemic hyponatremia. Fluid accumulates throughout the body, producing edema and dilution of serum sodium. End-stage liver cirrhosis also produces hypovolemic hyponatremia. Reduced effective circulating volume stimulates water retention, leading to ascites and peripheral edema. A useful memory aid is to associate volume status with the underlying disorder. Hypovolemia points toward fluid losses. Hypovolemia suggests fluid overload states. Euvolemia strongly suggests syndrome of inappropriate antidiuretic hormone. Recognizing these categories is essential because treatment strategies differ considerably. Syndrome of inappropriate antidiuretic hormone often responds to fluid restriction and correction of the underlying cause, whereas hypovolemic and hypovolemic forms require different approaches. The key takeaway is simple. A patient with severe hyponatremia who appears clinically euvolemic is most likely experiencing inappropriate antidiuretic hormone secretion. Therefore, the correct answer is option B, syndrome of inappropriate antidiuretic hormone secretion, or SIADH. This brings us to the conclusion of our comprehensive lecture on the clinical pharmacology of renal and electrolyte disorders. The primary source material for this presentation was the extensive BPL 5101 tutorial provided by Dr. Nath Arwa. For those looking to expand their clinical expertise in this area, I highly recommend routinely reviewing the KDIGO, Kidney Disease, Improving Global Outcomes, guidelines. Nephrology is a rapidly evolving field, particularly with the advent of novel biologic therapies for glomerular diseases and new non-calcium-based agents for mineral bone disorders. Staying updated with KDIGO is essential for evidence-based practice. Thank you for your attention throughout this highly technical and complex material. As future clinicians, Your mastery of these pharmacological principles will be vital in protecting renal function, safely dosing medications for patients on dialysis, and improving the quality of life for those suffering from end-stage renal disease. I will now open the floor to any questions you may have.